Well, I don't have PowerPoint. I was going to try to do PowerPoint, and then I had my laptop fixed, and now I don't have the slides anymore. So, Dr. Thomas asked me to speak, and I said yes, and then he said it's on a Saturday morning. I already said yes, and then I found out I'm the last speaker before lunch. So I'll try to be brief. Couple comments before I launch into the prepared part of this. One is I can't agree enough about Narcan. Narcan should be everywhere. It should be like the defibrillator. I just do not understand, like the previous speakers, why it's not more widely available. I work for Greenbrier. We're a traditional drug and alcohol treatment center. We can't treat dead people. It's too late. Narcan should be everywhere. I'm very curious, when Attorney Hickton gets back, I noticed that he went to school at Penn State, and went to law school at Pitt, so I'm going to want to know, oh, he's back. I'm going to want to know who he's cheering for. Yeah. A true attorney. All right. Well, you should have something that looks like this, that says, why are we addicts such a pain? And when I say addicts, I'm in recovery. Have been for many years. So if I say something that sounds pejorative about addicts, I'm including myself. Wise man, by that I mean Dr. Thomas, said the issue is not so much chronic pain patient as how we talk to them. That heartsick feeling, that why do they make us so mad? And I'm going to try to talk a little bit about getting past that. I'm going to try to look a little bit about ways to help. And I'm going to ask you to do a little soul searching about your practices, about your prescribing practices. Let's start with screening. It's not going to be easy to screen out the substance abusing patient. A lot of the things I'm going to talk about are common to most pain patients. We want to look at a lot of what I'm going to say today, I'm afraid has been covered a little bit already, but what kind of pain are we talking about? What kind of pain are we talking about? Oftentimes, as was said earlier, people want to treat the pain of everyday life. And I think we've developed a culture where we should not suffer at all, ever, ever, ever. One of my favorite poems basically says that you start life like a block of wood, and the more life carves into you, the more joy you can hold. And I really believe that if you don't ever experience that joy carving, that life carving into you, you don't really appreciate how good life can be. These medications work too well. Heroin. Heroin to me has been described to me by some of my patients as, a 6-hour bubble of awe. If it wasn't addictive, how does that sound to you? You're at work one day and you're having a horrible time, and I'm just going to slip into my office and get into my little bubble of heroin. Some days that's more appealing than others. Life is hard. Trouble with drugs is that they create a reservoir of guilt and shame. And drugs release you from that reservoir of guilt and shame for a while. And so people build up a reason to use. So I would say as a physician, part of your job is to look at their quality of life. What is it that they feel the need to medicate? Now here's the thing too, pain is very subjective. What one person considers extremely painful, and I don't mean just physically, I mean emotionally. In my neighborhood, you have kids crushed they didn't get into their college of choice. Like, this is a devastating blow. The neighborhood I grew up in, you got into college? And I'm sure people up and down the block were saying, "Do you believe that Montrose kid got into college?" Pain is relative. The drugs that are prescribed are very attractive. I love this quote from Keith Richards. If God made something better than heroin, he kept it for himself. Now, if you've seen Keith Richards lately, Trust your instinct. Trust your instincts. If you feel that you're being scammed, you probably are. You probably are. I'm amazed. If you ever have a chance, go to an open NA meeting and talk to the people about how they got meds. And you'll see people, just average folks, who scammed incredible amount of medications from highly qualified physicians. It's a skill, and people master it. People master it. We're going to talk later. We're going to talk a little bit about that a little later on. As I was doing the research for this, I knew about this website, and every now and then I visit it just to remind myself that I'm going to get fooled. I mean, I work in a rehab, and I know I'm going to get conned. It happens. But I love this. It was somebody on a website giving advice on how to get Xanax from the physician. And if you look at it, it says, the number one rule is let it flow. Just be conversational with the physician. And they advise, if you go in there, know the symptoms. You know what? Depending on which benzo you want, know the symptoms, so that you can have this. You can feed the doc your symptoms, in a way that he's going to say, "Oh, well, that sounds like an Ativan or a Klonopin thing." And then he said, I think this is really, really telling. He says, if they feel like they're the one who suggested it, they tend to feel safer prescribing. Absolutely. Absolutely. Don't ask for the drug. Let the doctor make a suggestion. Don't show your detailed knowledge. If the doctor suggests something other than Xanax, accept it and then come back. There is a whole cottage industry in teaching people how to get over on the physician. And folks are good at it. Folks are good at it. I've had this conversation with docs that I've met socially. I think I would know if I was being fooled, and I just, oh my God. Trust me. You've been fooled. I've been fooled. Beware of the late day patient. Nobody wants to argue at 5:45. They want to go home. Get in. My clients tell me, if you ever want something, Ken, it's funny how they tutor me on getting high. Like, I think you're missing the point. I'm supposed to tutor you on getting clean. But they will tutor me on getting high. And I say, if you ever need something from the doc and he's reluctant, get in late in the day. People want to go home. People want to go home. So ask for something late in the day. And then, if you don't get it, create a scene. Especially if you're someone who doesn't usually create a scene. Because it's those people who are always creating a scene, they go, that's just Ken being a jerk again. But if I create a scene when I really need the med, I'm more likely to get it. They also told me, don't be too upset if they say, here's your prescription, don't come back. Because who cares? The next prescription is a problem for another day. You've got the prescription for today. They were saying about Suboxone could be a bridge. Prescriptions are a bridge to my next addiction, to my next prescription. So, beware of the scene, especially late in the day. We don't do this. I wish we did. I wish we had better cameras on our parking lot. But I have a colleague who says, the best indicator of people's health is your parking lot, what goes on out there. Because that's where people are if they don't think you're watching, that's where you see who's, they're running across the parking lot to get there when the door's open, and then they're limping into your office. I need a referral. Yeah, I need a referral. Absolutely. I've got back pain, and then you realize that they're having sex in the car, in the parking lot. I'm a little suspicious. Beware of the client who can't possibly be abusing meds. The little old lady, sorry for that stereotype, but the little old lady who's sweet, she would never ever abuse meds, ever, ever, ever. She knows that she would never ever abuse meds, and so she is. Or she's selling them, or she's feeding them to her grandson, who has given her a sob story. Now those mean docs don't understand him, and she'll go to the pain clinic and get the med for him. Now, I have to say, too, and this is no offense to the older folks in the audience, and I'm not going to look at anybody because I've been accused. Why are you looking at me? My parents' generation, whatever the doc said went. And so they get a prescription, they keep it. And the other thing about my parents' generation that used to make me laugh and cry at the same time is, children of the Depression, we never throw anything out. So prescription bottles, I would go home and my mom, I don't know what possessed her, but all the medicines went up on the windowsill in the kitchen, over the kitchen sink. And there would be all these opiates lined up. Like, Mom, why don't you put a sign out, we're old, frail, rudderless. She would just pat me on the head, you know. Kenny, you've always been a warrior. I'm not coming to your funeral, I'll tell you right now. I like what Dr. Kunkel had to say about the oral fluids drug screenings. We do observed urines. But I'm, you know, however you do it, do drug screens. Do drug screens, do drug screens, do drug screens. For a number of reasons. Sometimes people balk at drug screens because they see them as invasive or there's some kind of social awkwardness about them. Do drug screens. You wouldn't hesitate to do a glucometer reading on someone who's diabetic. You know what? Drug screens are, addiction is a medical issue. Drug screens are the standard test for measuring progress. And the funny thing about drug screens is oftentimes you will find things you don't expect. Now I have to laugh, my colleagues at Gateway, I'm at Greenbrier. Sometimes they're with the two tire companies, Goodyear and Goodrich. We're kind of Goodrich. But they test to see if the urine is human. And oftentimes look at the urine as I've had them tell me that. But you know, someone will say, okay, Ken, don't test me. I'll admit that I have such and such in my system. Test them anyway, because then you find the whole panel lights up. All kinds of things. You know, even if you know there's going to be opiates in it, test anyway, because oftentimes you'll find alcohol, you'll find marijuana, you'll find things you didn't even know, what they are. Those of you who work with adolescents, the things that adolescents do to get high, just amazing, astounding. Greene County, we have a colleague who told me they're smoking horse dewormer down there. Horse dewormer, it cleans the worms out of the horse's intestinal tract. And it has strychnine in it, so when you smoke it, you hallucinate. Horse dewormer. Yeah. Drug screen. Drug screen, drug screen, drug screen. You'll often find they're taking more than prescribed if you get levels done. You'll also find sometimes they're not taking any, and as was said before, people are diverting meds. They're not taking any because they're selling it. And I want to go back to the stigma thing. I try not to judge people harshly. Adderall, not a pain med, but Adderall, last I checked, was selling for $1 a milligram. So if you have 30 milligram pills, that's $900 a month you can make without leaving your dorm room. So think of the worst job you ever had in college. I try not to judge people that are selling their meds, they're diverting them. It's part of the disease of addiction. And again, I'm an addict, so I try not to judge them harshly. Try not to judge yourselves too harshly too, because I think a lot of this opiate epidemic is people stealing meds. But I also think there's, no offense, a lot of overprescribing. We get people in on doses that just, as long as I've been in this field 30 years, and sometimes I'll see what people are on. How are you upright? How is it that you still can move and build up a tolerance, build up this immense tolerance? Baseline drug screens before patients are transferred to you. I also want to hit on the idea that when you do drug screens, you need to be upfront about what's going to happen if they're dirty. You need to be very upfront, about will you continue prescribing, if they're on probation, what's the relationship with the probation officer. You need to be upfront about the medical risks. If you are combining this with the medicine, your heart medicine, here's what might happen. You need to be very upfront about what the consequences are. Brief interventions. Here's what I also want to, if you remember nothing else I say, remember this. A lot of treatment is planting seeds. A lot of treatment is planting seeds. And I work in abstinence-based. We want to get you off of all the mood-altering chemicals. And a lot of people don't succeed the first time through. In fact, most people don't succeed the first time through. what happens is they have to come back 2 or 3 times before they finally get clean and sober. And what I tell the therapist when I was clinical director was, you're planting seeds. You are hoping that sooner or later life is going to kick them so hard that the seed it will jumpstart the seed's growth, and then they will get clean and sober. And that's been my experience with many of the people who've gone through Greenbrier. They didn't get it the first time, but they got the message. If you doubt this, anybody here willing to admit that when you were a teenager, you thought your parents were foolish at best? And then as you grow older, I'm amazed at how many times, when I was a young man, I thought my dad was very sweet, but not very knowledgeable. And now that I have children of my own, he was a genius. He knew exactly what he was talking about. Mark Twain said that when I was 16, I couldn't stand to have the old man around. He was so stupid. But by the time I was 21, I was amazed at how much he'd learned. You're planting seeds, you're planting seeds, you're planting seeds. Even if you feel like you're talking to the wall, keep talking. Sometimes people just one day get it. One day they get it. Now the sad thing is, oftentimes they get it because someone close to them died. They wake up in a jail cell. They have, a heart attack, at 30, but they finally get it. There's an NA slogan I love that says, many people have to feel the heat before they see the light. And I think that's true. Brief interventions, you're planting seeds, you're planting seeds. I love this expression mainly because I think I coined it. Somebody probably did before me, but manage, don't banish pain. We're going to manage, don't banish it. If we just completely put you in an oxycodone bubble, you're going to get addicted. If we teach you to manage the pain, you have a much better shot. Manage, don't banish. I can't hammer on this enough, this idea, people have this idea they should never feel either any pain or any guilt in our culture now. And you know what? Pain is a warning sign. Pain is instructive. Now, I'm not talking about, the pain of bone cancer, but I'm talking about the pain of everyday life. And as a culture, we've kind of gotten away from that idea, that we need to accept things. I had a really good first sponsor, and he said an odd thing to me early on. He said, the more people you love, the more funerals you go to. I thought, you really suck at cheering people up. I'm not liking this recovery thing so much. But he went on to say that it's a good deal. You get this whole lifetime with people, and then at the end there's some pain and you accept it. So, part of life is trying to enjoy it to the fullest, but also accepting oftentimes there's a price. There's a price, and most times it's a bargain. Step 1, 5 steps, staying clean, taking medications is an outline I wrote for our clients about if you have to take meds, or if you think you might have to take meds, here's a plan for you so that you can manage your recovery. The first step is you get clean. Physicians, you need to tell them, I cannot properly manage your health if I don't know what's going in your body. So if you're taking non-prescribed meds, if you're doing street drugs and alcohol, I really can't treat you well. And I think, no offense, but at least from the patient report, a lot of our patients aren't getting that message, that I can't treat you well. Now I have to go back, I have to laugh still at that other generation. My mother's attitude was, if your last name is on the bottle, that's close enough. So you may need to be clear that what's prescribed for you and you alone. You and you alone. And prescribed for you within a reasonable time period. You find the Percocet you got 2 years ago for getting your wisdom teeth out. You don't get to take them and say, well, they prescribed for me. We need to get clean and sober. That includes marijuana. I am just so tired of the marijuana debate. If you're on an opiate, it's a really bad idea. Whether you want to talk about whether it should be legalized or not, that's not my interest at all. I'm interested in people that want to get clean. Find a doc familiar with addiction. Now, here's what we tell clients, that's easier said than done. But I want to tell you, the docs, there's 3 docs you don't want to be, and these are 3 doctors that we encounter. The first is Dr. Feelgood. And please don't point if they're here. No. No, but it's that doc that is just over-prescribing and and lots of benzos and lots of opioids and, just putting people, again, into that bubble. Don't be Dr. Feelgood, because you can go to jail for that. Don't be Dr. Gullible. The dog did not eat the prescription, okay? And if you go to NA, you will hear unbelievable stories. You can't believe anyone would fall for that. My worst encounter was I worked with a doc at another agency, and he was a kindly old gentleman, but not a suspicious bone in his body, which is a bad thing for a doc. And he once said to me, and people were coming back to get Ativan scripts. And he would say, why do you think he keeps dropping his Ativan down his sink and not the lithium? And I didn't even know how to answer. And the funny thing is, he felt sorry for me because he thought I was so jaded. Ken, you think everyone's an addict. Okay. And don't be Dr. Too Busy. And here's what I have to apologize to you, because I know that many of you are just swamped. Just swamped. But one of the tricks that addicts use is you find a doctor that's busy, they don't have the time to argue with you. They would rather give you a script. So you go and see Dr. Too Busy and ask for what you want, and they don't feel like they can explain to you all the reasons why this is a bad idea. It's much easier to get a prescription. Don't be Dr. Gullible, don't be Dr. Feelgood, don't be Dr. Too Busy. Step 3 is we want you to taper off of things you don't need. Now, here's where the contract comes in. What we tell folks at Greenbrier is that you can't just take medication and ingest it. You need to work out a contract with a doc. And the doc's part is they're going to try to get you the lowest dose of the least addictive, if not non-addictive, treatment. On your side, you're going to do everything you can not to need that. So if you've got, swelling, pain, joint pain, don't go and get an opiate. Rest, ice, compress, elevate, do all those things and see if you can't get by on Advil. It's a contract between the two of you. And if either one of you doesn't live up to your end of the bargain, you need to do something else. A lot of our clients don't like that, but I want them to feel responsible. I don't want them to just pop things into their bodies anymore. Now, I don't want to leave you with the idea that I'm anti-meds. If I was in a whole lot of pain, if I had bone cancer, I'm pretty sure I would come see a doc and take something for it. I'm not going to chew on a piece of leather if I have bone cancer. I started my career doing dual diagnosis, mental health, drug, and alcohol, and I worked a lot with folks with schizophrenia. And it's like, no, take the medication. Don't drink, don't do drugs, but take the medication. If you need to treat something, treat it. Now, start with the least addictive first, but treat it. I think a lot of times people relapse because they don't treat a condition. And so they're not treating their pain appropriately, and so they finally decide, I'm just going to go out and get some heroin. You know what? Treat it. And then step 5, we want you to revisit the first 4 steps. Take stock. Do I really need this? Do I really need this? I like the example from before where the patient comes in and they're taking all the opioids even though they're not working because they take all the opioids. It's just what I do. I get up in the morning and I take the opioids. I have to laugh sometimes. We'll get folks who come into the rehab and we'll ask them what medications they're on and they'll tell me what color pill. I take 3 of the yellows and 2 of the greens. Do you know what those are? Jelly beans? Eds? Well, could you call your pharmacist? I'll call the pharmacist and tell him you're taking 3 greens, but I don't know. He's going to have any more idea than I do. You should bring them in. Referral to treatment. When in doubt, refer. When in doubt, refer. Look, the rehabs, we hire people to assess. That's all they do is assessment. So, they're a good resource for what level of care someone needs. What level of care someone needs. Even if they don't go to treatment, you've planted a seed. You've planted a seed. If you want to send them to, a traditional rehab like we are, you want to send them to a methadone clinic, and they resist, at least you've planted the seed that something is wrong. Something is wrong. We need to do something about this. Refer them to treatment. And I have to tell you, a lot of them will get very upset talking about the stigma. There is still a big stigma out there. It's sad. It's very sad, but people still feel it. People still feel it. I had a neighbor not so long ago whisper to me, which amazed me because we were standing in our yards. I don't know, but the NSA was surveilling us. Do you know heroin addicts? I know a lot of heroin addicts. No, really? No, yeah, I do. They're not like aliens. There's quite a few of them. But they're not the stigma. The stigma. Resistance. I realize I'm racing through this. Okay, resistance. Theirs. I'm going to present their point of view a little bit here, and I hope you're not offended. Screw you and the horse you rode in on. Yeah. Don't take it personally, blaming people, and I'm going to say that's the other thing you should remember. Don't take it personally. A lot of what we addicts say to you isn't really meant for you, it's meant to manipulate you. If crying will get you to write me, son, I'll cry. If yelling at you will get you to write me, son, I'll yell. It's not really connected to you. But anyway, if I got addicted by following a physician's prescriptions, I'm likely to really not like all physicians. And sometimes my heart goes out to them. You'll see, again, the stereotype, the little old lady, and she's addicted to painkillers. That she had no history of addiction. She had hip surgery. She's addicted to painkillers, and now she's sitting next to the guy with the tats and 6 piercings. And what do I have in common with him? And then I'll have to sit down with her and say, here's what you have in common. You've both been dope sick, you've both diverted meds, you're both, in danger of overdose, and it's a little scary. I'm always afraid she's going to come back the next week with a nose ring and grandpa. Resenting the physician is too easy because with a stroke of the pen you can give them what they want and you won't. And to them, to you that may seem completely reasonable. To them it's like, oh, how much would it kill you to write it? Not realizing it's your license. Blank are to blank as blank are to blank. Fill in the blanks with opioids, SSRIs, benzos, and NSAIDs. Here's the thing. We addicts, we don't want to just be relieved of whatever our discomfort is. We want to feel it. So you take the example of Xanax versus Paxil. Xanax and Paxil both work very well for anxiety. But Xanax is Paxil is one day you go, I'm a little anxious getting up here, but I'm not nearly as anxious as I was. To an addict, that's not good enough. I want So, you as a doc might have to do a lot of work to get them to take Paxil as opposed to Xanax. The other weird thing, I'm getting a little off track here, is some of the meds that we give take 6 weeks to 3 months to build up a dose. To an addict, that makes no sense. Alcohol is my drug of choice. If you said to me, Ken, you're going to have to really get liquored New Year's Eve to feel it Valentine's Day. What? Or, why would I do that? This is a little sad, but closer relationship than an addict and his drug of choice. I love my wife and kids. I adore my wife and kids. They can only be next to me. Heroin can be in every cell of my body. You cannot have a closer relationship. And that's why people do, you look at them and say, how could he abandon that beautiful family? Because the relationship is closer. Until you can get it out of your system, not easy. Not easy. It's like that proverbial coming between the mother bear and her cubs. expect some bad reactions. Don't take it personally, don't take it personally, don't take it personally. Your resistance. I think I gave you a little poem about worrying about the DEA. Feel free to prescribe any pill, lure tabs and vikes at will, but write far too many, and by that we mean any. Well, maybe you'll get your license back on appeal. Lots of docs fear that. And you know what? Maybe some reason behind it. Beware of more, louder, harder. More, louder, harder is the idea that when something doesn't work, we're just going to do more of it. So if this didn't kill the pain, then let's just double it and triple it and keep on going. And it's a bad idea. Sometimes we need to step back and look at what we're doing. A lot of physicians feel like they don't have enough training. I heard an expert speak. He said he spent 2 weeks on Rocky Mountain spotted fever and 1 hour on addiction. Never in his whole career treated a case of Rocky Mountain spotted fever. Has anybody? One person? Now you're dating yourself. I bet some of you treated an addict or two. Treatment is inadequate. Sometimes I'm going to get back to this. It's easy to underestimate someone who's addicted and not realize the skills it takes to maintain, like someone said, a 30-year heroin habit. The skills to maintain a 30-year heroin habit, that's a talent. An example I give you is, you graduated summa cum laude from Penn, you did your medical training at Johns Hopkins, you have numerous awards and honors, and you think, who could fool me? Look at your adversary. He woke up dope sick and broke and ended the day with $20 and a bundle of heroin. Don't underestimate your adversary. I always thought we should put a junkie in charge of our treasury. Balance the budget. Now, we won't be able to take phone calls from other countries. Where's that battleship we loaned you? Yeah, don't underestimate. Don't underestimate. In summary, don't take it personally. Don't take it personally. And I have to say, as I sit up here, I've been doing this 30 years. There's days when I've had enough. And I feel bad for my kids sometimes, but I don't even tell them. Don't even tell me a little white lie. People have been lying to me all day. Daddy's not in his happy place right now. Well, before you feel sorry for my kids, my son is a bit of a joker, and he likes to tell people that his daddy watches grown men pee. And not give them any context. Yeah. So don't feel too bad. Feel bad for my daughter. Try to understand the closeness we addicts feel to our drug of choice. I've been sober almost 28 years, and people will say, don't you hate booze? I'm like, no. That's the problem. I still love it. I still love it. Don't underestimate the patient's skill in obtaining drugs, and remember above all else, when you feel like you're getting nowhere with your clients, you're probably planting seeds. Maybe not you, but maybe the next doc they'll connect with. That's all I have. Questions, comments, or a strong desire to go eat? Oh, yes, sir.
What is the answer to the question on the back?
Oh, that's for you. What would you do if it was dirty? Would you discontinue? It depends on your practice. Would you insist they go to detox? What would you do?
Ken,
Yes.
do you think that the patient always needs to reach a bottom before they can turn?
I think bottoms are relative. Unfortunately, for some, the bottom is death. For some, it's a much higher bottom. I think, I want to go back to something you had said about, I forget how you put it, about if you make it too easy. If you take away all the pain, there's no bottom. So, it's all relative, what's bottom. Unfortunately, for some people, the bottom is death.
One question/comment. I worked with a patient one time who had a drug addiction. I did mental health for 30 years. But what they did was, they said, if you do this, if your urine is dirty, you're going to jail. They said that like 5 times.
Yeah.
Which my thought is, they should go, if not into jail, down to the jail the first time it happens. I think that works better and help them through the process versus, I understand it was a difficult time, don't do it again. I understand, don't do it again. Where I think it negates their responsibility, and actually our responsibility too, and it's very frustrating. Do you know how to work with that, or have you had a lot of experience with that?
Oh, that's one of my pet peeves is, the question was, why do we tell them you're gonna go to jail and you don't, we tell them you're gonna go to jail and they don't, we tell them you're gonna go to jail, and then we send them to jail forever. Like, the first time it happens, a very, very short jail sentence, but absolutely tie the consequences to the behavior. And then I'm also a big proponent in, let's start treatment in jail. Let's start the treatment in jail. By the time they get, you don't send them to jail, you don't send them to jail, you send them for 5 years. By the time they get out, yeah, absolutely. Yeah, the system is broken. That's what it's about. Anybody else? Thank you very much.